Hey, it's Gonzo Gonzalez, and you're listening to Dr. Gonzo's Talking Points. The first thing that I wanted to do is thank everybody for listening and sharing. It's been a really fulfilling experience to have a podcast like this and have a lot of people in the community share and listen to the podcast. Remember, you can always download it when you go to the Ask Dr. Gonzo Anything channel. You have a button there that says download, so if you're really interested in keeping the episode and listening to it on your way home, that's another really easy way to actually access and save the podcast. So again, thanks again for listening. Today I wanted to do something different. Rather than having a guest on the show, I wanted to talk a bit about something that I've been observing and reading on the internet over the last week. There's a couple of groups that I'm part of on the internet, and one of them happens to be on Facebook, and it's a group that's has as a support for people that have or are undergoing open heart surgery. And there's a bicuspid aortic valve group, there's a heart failure group, there's a mitral valve repair group, and there's a heart surgery or heart valve surgery support group. And I want to first to give a shout out to all those groups because there's some really good content that's happening in those groups. And for those of you listening that may have had open heart surgery or are facing the prospects of receiving open heart surgery, I want to encourage you guys to enroll in these groups because there's a lot of really good conversations happening. But what was obvious the last week when I was looking at these groups and reading through these posts is that there's still a lot of questions about postoperative management and what happens postoperatively to a patient that is undergoing open heart surgery. So I figured that I'd give you some pointers and key points about what is it that I tell patients when they come and visit in Valve Clinic, what to expect after open heart surgery. And so the point of the podcast today was to go over some of these points so to potentially help individuals that are facing the prospects of open heart surgery. What is it you're going to go through? So here we go. So the first thing that I tell patients, irregardless of the type of surgery, although let me couch the statement by saying that if you're going to have standard bypass surgery, isolated valve surgery, either aortic valve or mitral valve surgery, these points happen to be true. This is the typical answer that I give patients when they come in to visit. Now, it'll change depending on your overall condition going into surgery. So patients that have more comorbidities, meaning renal failure, bad lungs in the form of COPD, decompensated heart failure, history of strokes, things may be different. But in overall, this is the typical pattern that I see people go through when they undergo open heart surgery. So the first one is that in our center, most patients that have to have open heart surgery, the process of surgery takes about 6 hours. And what I define as the process of surgery means from the time that you go into the operating room to the time that you leave the operating room. That's called the time of surgery for us. Now, what we do in terms of the procedure, whether it's an aortic valve replacement or a mitral valve replacement or bypass surgery, usually on average what I see is that the operation per se takes about an hour and a half. Okay, so that's kind of a ballpark figure of what is it that it takes to do a procedure. Now, after you leave the operating room, most patients, if not all patients, go to the intensive care unit. And that's where your family members will see you. Now, the following comments are aimed more to the family members because they're not prepared and sometimes is to see their loved ones in the intensive care unit with the monitoring devices that the patient has. So when you arrive to the intensive care unit, You will have a breathing tube more than likely in your mouth, and that is called a endotracheal tube. It helps to maintain you breathing while you're recovering from anesthesia. Second thing is that you have monitoring lines, and those are Swan-Ganz catheters, lines in your neck, and also you have a bladder catheter. Those lines are aimed as to measuring your cardiac function. And as we all learned in medical school and in residency, the urine output happens to be one of the most sensitive measures of end organ function. And so everybody that has open heart surgery in our center will receive a bladder catheter, and that is entailed to measure end organ flow. Patients also come out of the operating room with chest tubes, and those chest tubes are aimed at collecting fluid or blood that accumulates in the chest after open heart surgery. It also, sometimes we also put them in the chest cavity where the lungs are, and that is aimed as to trying to remove any entrapped air that you have around your lungs and help your lungs expand. The other nice thing about chest tubes are that any bleeding or any excessive drainage that occurs because of the surgery or because the patient had open heart surgery and has been on blood thinners, we can detect whether there's excessive bleeding or not. And sometimes, and in very rare occasions, we have to go back to the operating room and wash out any blood clots or any fluid that's accumulated around the heart, because we want to prevent a condition called tamponade, which is when blood gets around the heart and there's so much of it that it impedes with the proper function of the heart. So the chest tubes are aimed, one, for therapy, but also diagnosis. Now, once you're in the intensive care unit, depending on the program, patients get extubated that same day. What that means is the breathing tube comes out. Or in some occasions, and I typically do this because I don't like to be doing a lot of things in the first 24 hours because I want everything to start healing. I want the bleeding to be controlled, and I don't want anything to disturb the calm state that happens after open heart surgery. And so what I typically do is I keep the patients asleep for at least 12 hours. Now, during that time, you're getting resuscitated, you're receiving fluids. Some people may receive blood transfusions. Some people may receive diuretics to try to get rid of any excess fluid that they have. And if you're on medicines that are helping your blood pressure or helping your heart, we also try to titrate those down in order to get you to a normal state. So the first 24 hours are critical because a lot of hemodynamical changes and volume changes are occurring, and managing the patient is much more easier for me and in my hands if we maintain the breathing tube and the patient is asleep during that period. Now, let me guarantee you that when you have that breathing tube in, we do everything to maintain you asleep. So you're not feeling anything, you won't remember anything, and it is actually a pleasant sleep. And so that's what we do in the first 12 to 24 hours after surgery. Now, the day after surgery, after we take out the breathing tube, then we start trying to get you back to what you were before surgery. Now, there's a lot of anxiety with people about taking that breathing tube out, and it's completely understandable. But most people don't remember the breathing tube coming out. In fact, those first 12 hours, you're still grogged up and still have anesthesia on board, so that a lot of people don't remember that time. Some people do, but most people don't. But after the breathing tube comes out on post-op day number 1, we start working on also getting the catheters out of your neck, the chest tubes out of your chest. Those don't hurt. What most people say is that it feels funny. It's a weird sensation, but there's no pain associated to that. Now, with regards to pain associated to the sternotomy, I'll tell you that one of the most curious findings that I've seen in my career is that most people complain not about the sternum hurting. It feels sore. But if you have bypass surgery, most people ironically complain of pain in the incisions in their legs. Now, I can't explain that easily, but the reality is that I see that even if they do small incisions or they do it endoscopically. So the most sensitive part about this whole thing happens to be the leg, and just be prepared for that, and not necessarily the sternotomy. Now, if you don't have any bypass surgery and you don't have to use your leg to do bypass surgery, then it's a moot point. But most people say that the sternotomy, it's not painful, it's actually sore. But for those that do have pain associated to the sternotomy, we do then give them medicines and narcotics to try to alleviate the pain and get that edge off. Now, that post-op day number 1 is usually marked by a lot of fluid accumulation because of all the fluids that we give the patient or give you during the procedure. And so what I typically do for most patients is that we will give them medicines that are called diuretics to try to excrete, to remove that excess fluid that you have. And what we want to avoid is that excess fluid building up in your lungs, because then it soaks up all that fluid and then gives you a congestive heart failure, but it's an iatrogenic congestive heart failure, something that we cause because of all the fluid. So commonly, I'll put patients on 40 milligrams of Lasix twice a day. And if they're on dialysis, then, before surgery, then we'll dialyze them and try to get as much fluid as we can to avoid them having all this swelling and puffiness that happens after open heart surgery. Now, mind you that swelling and fluid retention after open heart surgery is very common, and in some cases can go on for a few days to maybe a couple of weeks after open heart surgery. And in there lies the reason why we continue to maintain patients on diuretics after they go home and are discharged home. So going back to the post-op day number 1, it's on post-op day number 1 that we start giving you something to eat or drink. We try to maintain the number of or the volume or cc's of fluid that we give you controlled so that we don't overdo it, because we're trying to get the excess fluid off. A lot of people complain that they're really thirsty, and so we do start giving them something to drink. And sometimes by the evening, we also give them a diet. Now, you don't have to eat the food if they bring it to you, because I know that people's palate is not back to normal, and their taste buds are not back to normal in the early postoperative days because of the anesthesia, because of some of the medicines we're giving you. So it's very common that people are not that hungry after open heart surgery. And so we do give you a diet. We do get you out of bed. A lot of our patients, we get out of bed and sit in a chair. And then the most important thing of all that happens in post-op day number 1 is taking deep breaths. It's important to take deep breaths and to expand your lungs, and you will have a respiratory therapist with you helping you do this little machine that we call an incentive spirometer, which goal is to expand your lungs. And it's breathing exercises that are aimed at protecting you from getting pneumonias or any problem with your lungs after open heart surgery. Now, after the first day, or post-op day number 1, a lot of patients are transferred to telemetry. We don't keep the patients in the intensive care unit commonly. And we transfer them to telemetry, in which is basically the place where you will reside for the next 3 to 4 days. Now, when you're in telemetry, we start transitioning you from IV medicines to oral medicines. We start working with you and physical therapy to get you out of bed and begin walking. The transition from getting to bed and into a chair and getting out of bed, we also teach you so that you're not putting too much excessive strain on your chest. And the nurses and the physical therapies teach you how to roll out of bed, how to hold on, and then how to cough and take deep breaths while you're holding onto one of these cool little heart pillows that we give everybody that receives open heart surgery. And that pillow, oftentimes, by the end of your hospitalization, is full of signatures, because it's got a little pen, and everybody signs the pillow after or while you're in the hospital. So 3 days or 4 days after surgery, you're still in the hospital potentially. A lot of people, particularly those that are receiving a mini approach to your valve or to the valve, can leave as quick as 3 days after surgery. If you have to have a full sternotomy, I've had people leave or want to leave 3 days after surgery, and it's totally fine as long as they're able to care for themselves in some shape or manner. It is very rare for people, excuse me, it's very rare for people to leave the hospital and have to go to rehab. But in older individuals and people who are a little bit more sicker and frail, it's very common that we get a social worker to work with them to get them to some form of rehab. But if you go home, usually we feel very comfortable that you will be able to do the same things that you're doing in the hospital without much aid. And there are a couple of elements that are important for us in making a decision that to send you home. The first one is that you can control your pain of your sternotomy or of your incisions with oral medications. The second, that you're able to take some form of food. And the third one is that you can walk around without any major assistance. Those are typically the three cardinal things that we look at patients before we send them home. If you're able to do all those three things and you're comfortable, and we then discharge you home. Now, the process of going home is different for everybody. People do ask me, what medicines do you have to go on? And there's 4 medicines that I typically discharge patients on, unless they can't tolerate or there's a clear contraindication to do that. Number 1, it's a beta blocker. It's a medicine that's used to slow down your heart, and it's actually proven to aid in survival after open heart surgery. Second one is an aspirin, and we put patients on baby aspirin. That's another common indication in need that is associated with long-term graft patency and survival after open heart surgery. The third one is a blood pressure medicine, and the fourth one is a anti-lipid medicine to prevent calcium or cholesterol buildup in your coronary arteries. So those are the 4 medicines that we typically will discharge patients on. Now, let me be clear about that. Not everybody gets sent home on those 4 medicines because, I'm sorry, and I missed the 5th one. A lot of people go home also on diuretics. Now, the first 4 ones, or the first 4 are the ones that you will have to take for the rest of your life. But if you can't tolerate them, if you have complications associated to them, we typically take them off, and we work with your cardiologist to try to remove those medicines if they're giving you a problem. If not, those medicines, we usually ask people to stay on them for life. Now, diuretics, I usually keep them on for about a week or 2 after your discharge, because there's still the potential of fluid getting built up in your lungs, in your legs, or in your body after open heart surgery, and so that staves off that need. And so we send you home. I do tell people that if they're comfortable as to doing stairs, they can go upstairs. There's no really contraindication to doing that. With regards of driving and flying, so there has been this thing about sitting in the back of the car and not sitting in front, and there is a I don't know if it's, I don't know where it started, but somebody must have said and propagated that the reason that they want them sitting in the back is just in case the airbags deploy and the seat belts and all this stuff. Well, the bottom line is that whether you're sitting in the back or the front, you got to have to wear a seat belt. The second thing is airbags. Nowadays, most cars are fitted for airbags, and they come from every direction. I think that if you're in a car accident that's bad enough for your airbags to deploy, I don't think that it matters where you're sitting. It's going to be a heavy crash. So in my mind, it doesn't make a lot of sense whether sitting in the back or the front. But I'm not gonna say that if you feel comfortable sitting in the front, not to sit in the front. If you feel comfortable sitting in the back of the car, well, then sit in the back of the car. I just don't know where that came from. And I am not so sure that I understand the need for it. So I don't care where you sit, as long as you're not driving. I'm a stickler about not driving for the first month. And the reason for that is that not because you may get into an accident, but some jerky moves are difficult to do when you have a sternotomy. And so you may not be as efficient as making those moves. And so I want to prevent somebody from hurting themselves and therefore from hurting others, because you may be less inclined as to moving that. So I meant moving your arms and your steering wheel. So what I commonly tell patients is drive. You can start driving a month after surgery and when you're off your narcotics. If you're still taking narcotics while you're a month after surgery, then I advise people not to be driving. Now, when you go home, we send you home with physical therapy. Now, physical therapy is aimed as to getting you stronger. It's called cardiac rehab, and it's like going to a gym. And we always can figure out with our case manager a location which you are able to receive that type of therapy. And it's like going to a gym. It's 3 times a week, and basically the process goes on for about 4 to 6 weeks. That's the common amount of time that I see patients having to need physical therapy, cardiac rehab. And during that process of healing, you'll see that things will start feeling normal. Your strength will start getting back. You're not as tired. But it does take a process, and I do think that most people between 6 to 12 weeks is when they start feeling normal again. I commonly see patients a week, a month, and then at the 3-month mark after surgery. And the reason I do that is because I really like to make sure that everything you are moving in the right direction with regards of your rehab. I like to look at the wounds and make sure that they're healing properly, that you're not having any problems with infection, which commonly happens after you go. Not commonly, but can happen when you're at home. And I just want to make sure that you're okay. The other thing that I like to make sure is that your X-ray is okay, that you don't have some uncollected fluid around your lungs, and if there is, sometimes we'll send people to radiology to have a small catheter or needle drain put into your chest to drain that fluid so that your lungs can expand. We also revise the medicines that you're on, make sure that if you're on blood thinners, you're taking them properly, that your levels of anticoagulation are okay if you're taking Coumadin or drugs that we need to be measuring, things like the INR. We listen to your valve. Usually at the 3-month mark, we will get an echo. At the month mark, we will get an echo. And that echo basically is done to make sure that if you did have a valve, the valve is working properly. If you had a valve repair, we make sure that the valve repair is holding. And then so we follow you during that period of time. I want to remind people that most people who need to get readmitted to the hospital after open heart surgery do so within the first week after surgery. After the first week of surgery, the chances of getting readmitted because of something associated to your surgery diminishes considerably. Not that it can't happen. And it's very important to remember that also, depending on your other comorbidities or risk factors that you may have, you still may get admitted, but not because of the open heart surgery after a week after surgery. But if it does, I like to see the patients back in clinic to make sure that we can manage anything that would prevent you from having to go back into the hospital unnecessarily. And then basically at the 3-month mark, we just make sure that you're in your way to full recovery. And oftentimes by that time we've discharged the patient, or we're going to discharge the patient from clinic and then allow them to follow up with their cardiologist. Now, your cardiologist will want to see you at some time, and there is not a standard answer for that. I've had cardiologists want to see the patients a week after surgery. I've had cardiologists tell me that they want to see their patients back 6 weeks after surgery. Now, if you're having problems and your medicines need to be adjusted, I usually encourage you to see your cardiologist sooner rather than later. And if you can't get a hold of them, oftentimes what I tell patients is to call me, because I'll call them directly and help you get in to see your patient, to see your cardiologist, I'm sorry. And then the last thing is going back to work. Now, For people that are working, most of the time, if they have sedentary jobs or desk-like jobs, I tell patients that most of our patients return to work on average between 3 to 5 weeks after surgery. So that's kind of the amount of time that they usually are out. Now, for sure, if you're not feeling well or if you're having problems or anything like that, well, that period of return to work is longer. And so that's return to work. And so I think that those are the easy pointers, or the pointers that I have for patients that are undergoing or facing open heart surgery. If when you listen to this podcast, you find that I haven't covered a particular issue, do me a favor, leave something in the comment section down below, and I will make sure that I address it. So I hope that this is a really helpful resource for you to prepare yourself for open heart surgery. And again, if you have any questions, comments, just leave them below, and I will make sure that I answer them as quickly as possible. So again, this is Gonzo Gonzalez, and you're listening to Dr. Gonzo's Talking Points. I hope this podcast will help you, and look forward to our next visit, and see you in the next week. Thank you.